Good afternoon, everyone. We welcome you all to this session on common retinal disorders, where we'll be covering a plethora of retinal conditions and their treatment modalities. So I welcome all the audience and also all the speakers.
Yeah, Dr. Nilesh, you can
So our
start.
first speaker is Dr. Nilesh, and he'll be speaking on biologics, biosimilars, and biobetters, understanding the basics.
Thank you so much, ma'am, and I would like to thank
This term is
AIOCMTC2.
becoming very fancy now. B. All
Yeah.
B.
So I would like to thank AIOCMTC Scientific Committee for providing me this opportunity. I'm Dr. Nilesh Kumar. These are my financial disclosures, and these are our contribution. We have been publishing for last 4 years. We have around 25 papers on biosimilars and biobetters. So this is the group led by my mentor, Dr. Ashish Sharma, and I was his resident for 2 years, and we had published around 20 papers at that time, and then we have continued the journey. So what are biosimilars? What is the public perception? The public perception is this. The original is Mohabbatein, and in a Kapil Sharma show, a skit is happening. That is biosimilar, a cheap copy, a generic medicine. But is it so? It is not like that. These are two different molecules. They share the same basic structure, they share the same efficacy, and they share the same safety, but they are two different molecules. So it is not a generic copy, as we see in a normal pharmaceutical, but it is a complex protein. By definition, it is highly similar to approved biologics, notwithstanding minor differences in clinically inactive component, having similar safety, purity, and potency. So every change, the primary amino acid sequence is same, but then there are post-translation modification, and that will lead to biosimilars. So how the biosimilars are manufactured? After the patent expires, actually it starts much before the patent expire, but for legal purposes, it starts after the patent expire. Reverse engineering is done of the proprietary molecule. That basic amino acid sequence is interpreted and kept the same. So if it is having the same, it is having the same primary structure, but the secondary, tertiary, and quaternary structure might be different. The site of action should be similar to the innovator. That is a must. And cell line for production might be different. So what cell line was being used 5 years earlier, 10 years earlier, 20 years earlier, that might not be same, but it has to have the same purification. The preclinical and analytical studies to prove similarities with innovators. So a lot of these comparisons happen in lab rather than on patient. They do a spectroscopy and see if there is a similarity is established, and then large number of pharmacokinetic and pharmacodynamic studies are done to compare the molecule. So you can see for the innovator molecule, these studies are very limited. A small number of analytical study is done, or preclinical study is done, and most of the clinical studies are done on the innovator molecule. But for it becomes opposite for the biosimilar, where patients trial is very less. So across the globe, there is a big concern across the globe that only 3 months data is taken before the drug is approved as a biosimilar, and that might might make it cheaper and might make it unsafe. But the clinical trial design is for equivalence, and equivalence can be proven in 12 weeks, not more than 12 weeks. As we go ahead, the equivalence might differ. So in the first 12 week only, we have to prove the equivalence, but the safety trial and the monitoring, efficacy monitoring and safety monitoring goes on for 1 year. So the trial runs for 1 year, but equivalence is taken at 12-week endpoint. And this equivalence is taken differently in US FDA and the European. In US FDA, it is taken as visual acuity. In Europe, it is taken as central subfoveal thickness. So a receptor for all these diseases, this is also a extrapolation of indications. So if a biosimilar is approved for one indication, it can be extrapolated and used for all the indications that is being provided for the innovator molecule. Legally, it has to take, like Intas has taken for Razumab, it has taken for myopic neovascularization and all, but it is not mandatory, it can be extrapolated as well. What are the pros of biosimilar? Why do we need them? It is because the apparent reason is price reduction. There's direct discounting from the innovator. As we can see, we must have noticed all these innovator companies who were not budging their prices now are coming with various schemes. Do pe ek free, Ailia lo to second one is free, and then third ke baad fourth and fifth. Nothing was there till the biosimilar came. So that is the direct price benefit, and the indirect benefit is from the lesser disease burden. So socio-economically, the patient is growing, the disease burden is less. The inapparent is wider availability and the local pharmaceutical having better approach. So Novartis, like I am practicing in a tier 2 city, Novartis came to me for 2 times in last year, Allergan came 1 time, but the local Lupin and Intas is visiting me every month. So they are giving me greater grassroots penetration also. So is it all rosy? It is not. It can be very scary. As we can see, the innovation, as the more number of generics in antibiotics started, the innovation in antibiotics started to come down. We don't have any new antibiotic in pipeline because all the company now started focusing on generic and producing the copy of the same antibiotic, and now we are in a crunch where there is antibiotic resistance, but we don't have anything new to offer to our patient. So this might also happen in biosimilar, but there is a way out. What is the future? Like Dhoni is a bio-better of Kapil Dev. Kapil Dev ke time pe there was only one ODI World Cup. Dhoni won Champions Trophy also, T20 also, and he won ODI also. Similarly, there is no standard definition of bio-better, but bio-better is something that was created as a biosimilar, but is having either a longer duration of action, more potent action, or more purity, more shelf life. Any one aspect is better, that what we call as a bio-better. So who can benefit for bio-better? 2 molecules that were very good, very efficacious, abicipar pegol, couldn't receive the FDA approval, and brolucizumab, that is Pagenex, is not being used because it is having inflammation. So if we add a pegtail in the brolucizumab, it might lead to lower inflammation, and it will help us with, it can be relaunched again. So thank you for the opportunity. Thank you. Sorry for overs.
Patent, till the time patent of Pagenex is there, you can't think of adding anything to your structure to minimize inflammation.
So,
What I'm saying is, you said in the definition of bio-better, abicipar as well as Pagenex. So can you today modify that?
bio-better is treated as a new drug, sir. If they apply for a application, it will be considered a new drug. New drug.
You can't modify Pagenex now because they have that patent for at least.
Yes, sir. The company itself, they can modify it, sir. Not nobody else right now.
Correct,
Yes, sir.
correct.
Thank you, sir.
Now we will invite, since Mallika is having same, almost similar topic of management diabetic macular edema, she opted to present at the end so that she can add any additional points if possible. And now I ask Dr. Lalit Verma to speak on optimizing management of PDR.
I hope the video will work this time. You see, in the morning session or afternoon sessions, we had an overdose of diabetic macular edema. So I'll be talking something about other aspect of visual loss in diabetes, that is proliferative disease. Thank the organizers for giving me this chance. You see, diabetes, you all know, is increasing. Couple of months back, we used to talk of 77 million diabetics. Today, we are 101 million diabetics. And 11.4% of India's population is diabetic. Primarily because all of us eat more and exercise less. That is the whole reason diabetes is increasing, not only amongst general population, but even amongst physicians and ophthalmologists. So there are 2 things which we are bothered in diabetes. One is the moderate visual loss that happens because of DME. Then severe visual loss happens because of the sequelae of PDR. What everybody should remember is that it's a silent disease. So all of us, including comprehensive, general, posterior segment, every ophthalmologist has a morally bound duty to make people aware, not only patient but within their families and self also, because it's a silent disease. Silent disease, all these patients have 6/6 vision. You see, even though this has NPDR, this is proliferative disease, but they all have 6/6 vision. Hence the role of seeking cooperation from public and even their relatives of regular checkup. As I said, moderate visual loss occurs because of maculopathy. Proliferative disease sequelae, either VH or PD or the TRD, that causes severe visual loss. So what I'm going to talk about the management, because companies are still pushing everybody to inject in every kind of disease. But I still believe that laser is the mainstay of PDR. Intraretinal injections, भैया चाय वाय सर बंद कर दो. Intraretinal injections still are not the main treatment in PDR. So please do not keep injecting in patients of proliferative diabetic retinopathy. So in PDR, thanks to DRS study long time back, we always do laser without delay, and even without HRC, that means even in mild PDR, we, at least I keep doing a full PRP. Not very tight, but we do a full PRP. Even in patients who have very severe NPDR, that means 4-to-1 rule or slightly beyond that, in the absence of PDR, we start lasering, because these are the patients who will progress to PDR very fast. Even in patients whom we are subjecting to surgery, so wherever it is possible to laser, in the interim period we can laser, because lasered eyes during surgery behave much better than the non-lasered eyes. As I said, PRP has been the gold standard. It is not now, it is there for last more than 4 decades. And we have had patients whom we lasered 30 years back, still maintaining 6/6 vision. The confusion started arising primarily because of this protocol S study by DRCR-NET, when they started comparing PRP with the intravitreal pharmacotherapy in this study, and what was found was it is non-inferior to PRP. But remember, this treatment is required regularly. So I'll just share how I use injections in this patient of PDR. So here is an example, right eye of a patient. Macula is pretty good, but there are massive fronts, very big fronts, a lot of non-perfusion areas. So in such patients, I will inject but always depend on laser. So did inject, you see this front did get shrunk, but depended ultimately on laser. So example, this is another example of a patient, again right eye. You see these fronts are very, very close to the macula, very close to the macula. If I laser here, it will cause some ERM formation or some issues. So therefore, once the fronts are very close on the posterior pole, inject and then laser afterwards. So good scatter laser photocoagulation has saved many, many eyes for decades, and all of us have examples for this. Anti-VEGF, despite repeated injection, cost and visits, etc., have adjunct role only and should not be pushed irrespective of the pressure. Only indication could be if it's a very well lasered eye, then again there are some oozes, you can consider giving anti-VEGF injections. But believe me, early vitrectomy in these patients also go a long way, because you remove the pull component, you remove the traction. So couple of slides about the other component of PDR, where laser will work, but after vitrectomy, where there have been sequelae. So again, all membranes do not require surgery. We were talking in the morning, all membranes do not require surgery. And patients who have TRD or vitreous hemorrhage and who have not been lasered should not be blindly injected anti-VEGF agents, especially in unlasered retinas. Again, this patient who has traction, but it is nasally and macula is pretty good, 6/12, hold your hand, believe me, diabetic retinitis are not to be taken lightly. This patient who should be given chance for surgery was injected with Avastin, but patient landed up in very severe kind of TRD. So do not go around injecting in PDR, especially with traction. So indications of vitreous surgery in diabetics are changing. No longer vitreous hemorrhage is the commonest indication. Commonest indication today is macular TRD. Macular TRD or a combined detachment is the most common indication in diabetic vitrectomy. So I'll just run through 1 or 2 videos. This is actually a vitreous hemorrhage. A simple looking surgery, but this lady presented with bilateral vitreous hemorrhage and could not walk. The culprit is this big, NVD here, which we trimmed. This, you should never do diathermy in such patients on the disc because it can transmit. So hold your hand. This surgery did not, last much. It was 10 minutes job because it was a total PVD. But what took more time was this laser photocoagulation. Disc macula are pretty healthy, and this patient has potential to gain back 6/6 vision. So these patients, I think, ultimately for long-term stability will require laser, laser and laser. So I spent 10 minutes in surgery, but 20 minutes in doing laser photocoagulation. And I'm very fond of doing laser in a proper row rather than tuck, 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 tuck here and there, because I don't want to miss out any areas. So we did take 15-20 minutes to laser this eye, and ultimately this was the end of surgery. Does not require any gas injection, just requires a simple airflow exchange. And this is the virtual end of surgery. This was the end result of this. So this was the other eye also of the same patient. So a couple of more videos about diabetic vitrectomy. This again is not a very difficult vitrectomy because the basic aim is to make a hole in the hyaloid, but do not forget this iatrogenic ooze which happens, do not leave for a very long time. So this has to be taken care of. Sometimes once we are doing a diabetic vitrectomy, like in this patient, it may not be easy to take out a nasal membrane specifically because of non-maneuverability of the instrumentation. So in such patients, we do change the position of the microscope and your sitting chair, and then you can change this port, and then whatever was nasal now becomes inferior, and then you can do your membrane surgery very easily. So this is the last video which I'll share. This young lady, IDDM, severely proliferative disease and presented with combined detachment. So here again, finding hyaloid plane is a challenge. This, you see there's a hole here, and there's a massive proliferation here. So here just slight pull at the level of disc. Don't pull it till the lens surface, but slight pull so that your 25 gauge probe can go inside that, the plane. So once the plane is found, then you go in between the folds of the retina and do this membrane dissection, but be very slow, very gentle to the retina, and keep using various instrumentation to segmentation. Segmentation is the answer rather than pulling. And then once some segmentation was done, I injected PFCL in this patient just to see what else needs to be done. And what was required now was a bimanual surgery, where we did put this 25 gauge chandelier, and with the forceps in one hand and the scissors, curved scissors in the other hand, you remove these fibrovascular pegs which are being attached to the retina. And sometimes you can use this curved scissors to dissect also gently, like is shown here. But the advantage of bimanual is precision. So you do not create much complications once you are dissecting this bimanual. So this will come out without creating any break or without creating any bleeding in these patients.
Lalit,
Yeah.
time is
So
up.
bimanual surgery, it has a definite role in the management of DR, and I frequently resort to bimanual surgery. So this is the post-op of this young lady. So I'll just show a couple of pre-post photographs and conclude by saying that in this era, the visual results of diabetic complex vitrectomies have improved thanks to the new instrumentation, new machines, and pre-operative anti-VEGF which have become available and make the job much relatively simpler. But answer is work slowly. Patience is the key. Don't pull too much. And as I said, outcomes have definitely improved. Thank you very much.
तिवारी के change नहीं की.
Next is CSR.
Yeah. No. We
Yeah.
noted that. Lalit,
Yeah.
in the management between PRP and anti-VEGF agents,
Yeah.
especially protocol S,
Yeah.
because a lot of people are there in the audience, they will have a need to have a clarity. If you are committing for anti-VEGFs, what precautions would you take in these patients, PDRs?
In any case, Ajit, I am not advocating to do anti-VEGF injections in
all
PDR.
cases. Yeah, okay.
In a non-laser, I will go ahead
Can
and
Dr. Neetu be ready for the other presentation here? Yeah. Yeah, tell me.
What I am saying is I am not advocating.
Yeah. Why?
Can you put on this slide? 1 second. Hello, slide.
No, slides are not
No, it's
required.
okay. I'm not.
Slides are not required because she need to be ready with the
No, I'm
presentation.
answering that
Slides
question,
comes.
Ajit. What I'm saying is,
Yeah.
that in PDR, injections are not required. That's what I'm saying.
You don't want to advocate injections, or you say one injection regress the new vessels
that I
only to
showed two
or
examples.
prevent the bleed. See, because protocol S has, because theoretically it has shown that multiple injections not only regresses the PDR but it saves the field of vision. It is very, very lucrative proposition they have come up with. But the downside of that is that if the patient do not come for follow-up, these cases can worsen like anything because the fibrosis will increase, the neovascularization, a rebound neovascularization which comes is very, very aggressive. So the cases can worsen. That's
So that
what
is
I
the
want to
reason, please.
advocate.
So, Ajit, that is the reason I'm not advocating at all. Because
Now
instead of passing on the blame to the patient, by India is a poor country, patient will not come for follow-up, please do not advocate. If it is a laser retina, if there is some bleed, then you do it. But as a primary mode of treatment, if you start injecting just that front will regress, believe me, long term is not good at
Will
all.
not go.
Even
Will
in
not
US now, it is no longer considered a viable option at all for
Yeah,
treatment.
yeah. No.
Where
Even
it was started in US, but even there it's not now understood that
So
laser has to be done.
let us not advocate injections in a patient of PDR.
PDRs.
That's all.
Yes. One sentence is do not advocate. Second sentence I would like to extend is if there is a front which is likely to bleed in immediate future, because laser today you do, protection will come 2 months later or 6 weeks later. So temporarily you give the injection and do the laser, it will have a long-term beneficial effect. With this we will switch to the next speaker. Yeah, Dr. Neetu, she will be speaking on central serous retinochoroidopathy.
Yes. Good afternoon, everyone. I'll be starting with one of my case, and this was a 43-year-old male presented to me with the diminution of vision left eye, and the history of smoking and alcohol was present. On examination, the best corrected visual acuity in the right eye was 6.6 with N6, and the left eye it was 6.18 and N18. Anterior segment both eye was normal. This is the fundus photograph of the right eye. And this is a fundus photograph of the left eye, which is showing the oval elevation in the macular area. And this is the OCT of the same patient, the left eye, showing the macular edema. Subretinal fluid in the macular area. And as far as the treatment is concerned, as it was a first episode, being a self-limiting disease, the patient was advised lifestyle modification and observation. And after 2 to 2.5 months, the patient was followed up. The vision in the left eye improved to 6.6. This is the OCT of the same patient after the 2 months. It's resolved. And now coming to what is central serous chorioretinopathy, it's a sporadic disease of the outer blood retinal barrier characterized by detachment of the neurosensory retina at the macula with or without the focal epithelial detachment and alter RPE, usually affecting the one eye. And it can be in two forms, acute or chronic. Acute generally resolves within the 4 months, and chronic, it is generally more than 4 to 6 months, and it has a widespread tract of RPE atrophy. Coming to the pathogenesis, it could be idiopathic or the choroidal pathology related to the choroidal circulation. Various risk factors are there will be loss of autoregulation, which leads to hyperpermeability of the choroid vasculature, causing increase in the hydrostatic pressure, and following which barrier function is lost, causing neurosensory detachment. These are the various risk factors for the CSCR. There is type A personality, emotional stress, untreated hypertension, history of steroid use, GERD, Cushing's disease. The various symptoms and signs are, it could be acute central loss of the vision, metamorphopsia, micropsia, positive scotomas could be seen, and there could be loss of color saturation and contrast sensitivity, and improvement of the vision with the plus lenses. The fundus will, what we'll see is a round or oval elevation in the macular area. There could be yellowish subretinal deposits forming a spot pattern and the fluid between the RP and the neurosensory layer. It is commonly seen in the middle-aged man, 30 to 50 years, and the ratio is 6:1, and in patients older than 50 years, the ratio is 2:1. How do we classify? It's a typical and atypical. Atypical variant is a bullous variant, RP tear, and association with the other retinal disorders. Histologically, it can be classified into 3 types. Type 1 is detachment of the neurosensory, detachment of the sensory retina, with the type 2 is RP detachment. Type 3 is intermediate, which comprise both. And these are the fundus fluorescent angiography findings. The most common is the smokestack pattern, and the second one is the ink blot pattern. This is the OCT of the what we see in CSCR with the subretinal fluid with the focal PED. More recently, it shows increased choroidal thickness in some patients as compared to the normal eyes. Coming to the treatment, observation, lifestyle modification, which can lead to spontaneous resolution, medical treatment, oral antisteroid therapy or anxiolytics, and the lasers, PDT, low fluence PDT or micropulse yellow laser. So coming to the take-home message, detailed history is important, lifestyle modification is helpful, close follow-up is required. OCT is as a tool to follow up, and it's a chronic disease, and elderly patients to be approached differently. Thank you.
Thank you, Neetu, for that crisp presentation. But I have a doubt. A patient comes with CSR, what is your first line of treatment? Today he has come with a history of 1 week blurring of vision, ring scotoma kind of it.
1 week history. So complete and detailed history would be taken, and lifestyle modification would be advised.
Okay, see, because I want to tell so many people are there, CSR, don't take it simple, because she has classified it in a different way. But now the evolving concept that is coming is the pachychoroid. That's why I stress the choroidopathy part of it.
Okay.
There is a CSR where the choroid is thin and normal. Probably there if you see a single leak which is extrafoveal, probably you go for laser. But the same patient, if there is a thickened choroid, this is a pachychoroid spectrum where there is a risk of neovascularization if you are going for a laser in these cases. So you should observe this and alert even if you commit for laser. Okay? And probably those cases may require injections in some cases. Okay? Thank you. Yeah, you want to say something?
Pachychoroid is becoming a dustbin kind of diagnosis. Whatever we don't understand, we are putting into pachychoroid. Typically, 5 things have been included, which include IPCV, and
Dr. Anusha
CSR.
is there? Dr. Anusha, please be ready in the other podium.
But only thing is, in all patients of CSR, we, if he's asking what is the first line of management, is masterly inactivity, do nothing.
Yes.
Do
First
nothing.
observation for 5 weeks.
Do nothing but rule out homeopathic medication and all these things which may contain steroids. Ask skin creams and inhalers and other things which may be relevant. So
I would just like to add, we should be familiar with the atypical presentations of CSR also. A lot of them are misdiagnosed, you know. They may have subretinal fibrin, which gives it a yellow appearance, and then these patients are thought to have choroiditis and given steroids. So, yeah, that's what I'm saying. Give more steroids.
Yes.
So CSR may have a lot of atypical presentations, and we all should be familiar with the atypical presentations as well. We don't always get this classic book picture like presentation.
Okay. Is Dr. Anusha is around? If she is not there, Anu Malik. Dr. Anu Malik. Yeah, please come forward, and she will be presenting on TAS versus endophthalmitis. Because PCV was there, actually, and that's why pachycardia brought before this thing, so that both are in the same spectrum. Actually, very rarely, but post major things, CNV and we need to tell them that this. Patient range New Delhi.
Good evening, everyone. I'm here to present the differences between TAS and endophthalmitis. Toxic anterior segment syndrome, also known as acute sterile inflammatory reaction or acute sterile anterior segment inflammation or sterile postoperative endophthalmitis. As we all know, endophthalmitis is inflammation of the inner coats of the eye with intraocular colonization of the infectious agents with exudation within the intraocular fluids. Both of these are bewildering entities, and at day one after surgery, it is very difficult to distinguish between them. But it is very important due to seriousness of the conditions and the divergent treatment strategies. TAS occurs due to toxic substance reactions occurring after any anterior segment surgeries, due to residues left behind by the items used during cleaning, sterilizations, or due to irrigating solutions with incorrect pH, osmolarity, due to stabilizing agents, denatured OVDs, endotoxins, heavy metals, or any other substance going inside the eye. Endophthalmitis can be due to preoperative, intraoperative, and postoperative causes. We have major outbreaks of TAS which have been reported throughout the worldwide. And various reported causes of TAS includes solutions, IOLs, ocular viscoelastic materials, BSS, antibiotics, anesthetics, intraocular dyes, and so on. TAS usually presents in 12 to 24 hours, and endophthalmitis in most of the cases do not show up until later. Still, there are reports of staph epidermidis and bacillus cereus endophthalmitis, which have TAS-like early presentations. Symptoms are usually rarely present or mildly present. There is little pain and significant inflammation in TAS, but in endophthalmitis, it is usually severe and pain is seen in more than 75% of the cases. In TAS, the vision is blurred within 12 to 24 hours after the surgery, and in endophthalmitis, visual loss can be profound. The ocular motility is full and painless in TAS, and in endophthalmitis, the patient usually presents with reduced or absent ocular movements in case of, along with proptosis and pain, and which can clinically point to diagnosis of panophthalmitis. In TAS, there is little conjunctival or scleral injection present. Furthermore, lid swelling is usually uncommon, but in ENDOPH, there is conjunctival or lid injections and swelling as well. The corneal edema in TAS is variable and widespread, and we have a diffuse limbus to limbus corneal edema, which is hallmark of TAS, and it could be permanent. In endophthalmitis, the corneal edema is more localized and patchy and tends to improve with inflammation resolution. Pupil is usually fixed and dilated. Often there are spotty, diffuse areas of iris atrophy. And in endophthalmitis, poor pupillary reaction due to increased levels of bacterial toxins and prostaglandins, as well as uveal congestion. There is mild to severe reaction with cells, flare, and hypopyon, fibrin reaction on iris and anterior surface of the IOL in TAS, and the exudates are usually white in color. But in ENDOPH, marked inflammatory response in anterior chamber with hypopyon is present. TAS present with elevated IOP, generally between 40 to 60 millimeter of mercury, and can have decreased IOP during early postoperative course, but progresses to permanent trabecular meshwork damage leading to secondary glaucoma. In endophthalmitis, intraocular pressure is usually variable. Frontal glow is okay or mildly poor in TAS, and in endophthalmitis, it is poor or absent. In TAS, there is no vitreous involvement. It can be clear, but spillover is possible. Vitritis is rare. Fibrinoid response is only present in the anterior chamber, and there is no retinal involvement. In endophthalmitis, there is marked vitreous involvement. There is inflammation of entire vitreous. There is retinal vasculitis and mild peripheral retinal hemorrhages can be found. On ultrasound B scan, vitreous cavity is usually clear in TAS. In endophthalmitis, there is mild to moderate intensity points echoes in vitreous cavity. There can be retinochoroidal thickening. We can find IOLs posteriorly dislocated in some cases. There can be concomitant retinal detachment, choroidal detachment as well. So whenever we are in doubt or there is worsening of the inflammation on steroids, or if we find some atypical features, we should go for vitreous gram staining and culture, which is usually negative in TAS. And we can find positive cultures in endophthalmitis, usually gram-positive bacteria, and 85.1% of all isolates can be due to gram-positive bacteria, 10.3 can be due to gram-negative bacteria, and 4.6% of all cases can be due to fungus. We have seen dramatic response with intense topical steroids, usually within 3-day course of steroid given every 1 hour in TAS. In endophthalmitis, the patients usually respond to antibiotics only. The visual outcome is good. The patient usually has 612 to 6.9 visual acuity. And in endophthalmitis, we can have worse results. Significant predictors of poor visual outcomes include initial visual acuity of light perception or worse, and infection by virulent organisms. Coming to treatment, topical steroids are the mainstay treatment for TAS, which can be given 1 to 2 hourly initially and then can be tapered. Steroids can be given in the form of gels, emulsions, ointments. We can also give topical NSAIDs. IOP management is very important. And in refractory cases, we have to give intracameral injection of recombinant tissue plasminogen, which leads to complete clearance of the fibrin reaction. We can also go for irrigation of anterior chamber, vitrectomy, and removal of IOL. And in cases of endothelial decompensation or permanent corneal edema, we have to go for surgical treatment. In endophthalmitis, systemic antibiotics, local antibiotics, topical subconjunctival, intravitreal injections, and vitrectomy are the options with us. So TAS has a multifactorial etiology. It can be difficult to prevent. Once it occurs, TAS can be fatal to the cornea and the eye. But it can be prevented. It is best to prevent the syndrome using all possible precautions. So whenever we are in doubt, it is always better to err on the side of infection. We should treat empirically as well infectious endophthalmitis via vitreous trap and intravitreal antibiotics. Because we are unable to reliably differentiate it from TAS until a therapeutic response to topical steroid is clearly present for several days, endophthalmitis should always be the consideration. Thank you.
Thank you, Anu, for highlighting virtually everything about TAS and endophthalmitis. Couple of points I will re-emphasize. One is, you said motility. Motility generally is not a point where we bother too much about the TAS. Because motility issues comes in panophthalmitis, not in endophthalmitis. Other thing is hypopyon is not a feature. Hypopyon can happen in both of them. Hypopyon just reflects the inflammatory load, that's all. Hypopyon is not the issue. Plus vitreous may be anechoic in both. Because vitreous, to pick up the signal from vitreous, you require some clump formation. And it has to be more than 0.7 then only it will show spike. Even in early endophthalmitis, vitreous can be anechoic. There is no issue about that. But culture sensitivity again, if it is positive, well and good, but negative does not distinguish. So, but rest of the points I think you have fairly well covered. And it's very important to distinguish between them, primarily because of one reason: the treatment modalities are vastly different. In one we load the patient with steroids, in other we do not. We have to give intraocular antibiotics. So that is the reason. But once you diagnose TAS, it is imperative that you hold on to the patient for at least same day or other day till the time you see pupil is dilated and glow can be seen. So because we are loading this patient with steroids from all the routes, so I will not ask the patient to go away. He will be there. After a few hours I will see him again. I will ask him to go for lunch, then come back again, then so. And then only I will see him next day. If slightest deterioration, intraocular antibiotics. The other thing is about vitreous involvement. There is something known as posterior TAS also. It's not TAS classically, which was described by Monson et al. Way back, was the anterior TAS. But posterior TAS is also known. Thank you very much for your lecture.
And one thing on B scan is the retinocoroidal thickening is there, no? That is more indicative of infective rather than this thing. That is there. Probably the earliest sign you can differentiate between inflammation
And the other very good message which you told was, if you are not able to distinguish,
keep
you see,
err towards the infection. That is true.
Thank you.
Dr. Samira is available in the. Yeah, please. Thank you, Anu Malik. Dr. Samira will be speaking on endophthalmitis, but it is in newborns. Again, very, very tough clinical condition. Srinivas.
It's not required. Yeah.
A very good afternoon to all, and thanks for this opportunity. I shall be talking on endogenous endophthalmitis of the newborn. I'll start with this case. This is a 1-month-old baby boy who presented to our outpatient department accompanied by mother for ophthalmic evaluation following septicemia. This baby was a product of non-consanguineous marriage, and gestational age was 36 weeks, postmenstrual age was 40 weeks, birth weight was 1.6 kg, and there was a history of NICU stay for 1 week. And baby was still in NICU, and the pediatrician had sent with the NICU nurses to the OPD. And in NICU, he was diagnosed to have fungal urosepsis and staphylococcus bloodstream infection and was started on intravenous antibiotics and antifungals. This was the baby, and when we saw under microscope, anterior segment was essentially within normal limits except mild congestion in both eyes. And this was the fundus picture. This is the RETCAM picture of right eye and left eye. There was vitritis present in both eyes, and there was yellowish fluffy exudate sitting on the retina in multiple areas in the right eye as well as in the left eye. The left eye fluffy exudate was very prominent, and it was protruding towards the vitreous cavity. We diagnosed fungal endogenous endophthalmitis in both eyes, and we planned vitreous biopsy and intraocular antibiotic in the right eye. And for the left eye, we planned for pars plana vitrectomy, vitreous biopsy, intraocular antibiotic. So this was a 25 case trocar cannula system, and the right eye actually was operated. It was not a pars plana vitrectomy, it was a vitreous biopsy because the affection was very localized and minimal. And for the left eye, we did a minimal pars plana vitrectomy, and we did a localized PVD surrounding the exudate sitting on the macula, and the entire exudate, it came out nicely, and yeah. And then we closed the sutures, ports with sutures. The right eye did not reveal any organism, and the left eye revealed Candida albicans. And the next plan was to inject intravitreal antifungal. Amphotericin was injected 10 doses in the right eye and left eye in NICU itself. This is the RETCAM picture after the second dose. You can see there were a lot of exudate here, and it was literally worsening in both eyes. Here new exudates appeared, and in the left eye also the exudate didn't go after third dose as well, and you can see now it is very prominent. And so we kept on injecting, and these are the serial RETCAM pictures of both eyes, and finally it started responding well. And this is the fundus picture after 10th dose of Elamfo, and you can see the scarring has started in the left eye, and this is a picture after the 11th dose. And the baby came after 1 month of post-injection to the OPD, and we could take a fundus picture with Chais Claros, and this was the picture. You can see there was parafoveal scarring in the right eye, and the left eye there was scarring sitting on the macula. And there was no sign of active inflammation or infection. And this was the OCT picture in the right eye. It was normal, and the left eye, you can see there was outer retina damage with foveal atrophy corresponding to the macular scar. We analyzed the clinical and microbiological data of clinically diagnosed patients of neonatal endogenous endophthalmitis from April 2013 to January 2023 at 4 tertiary eye care centers in 3 neighboring states of India. The detail of the study I am not going to present. It will come as a paper. What we saw, there was definite systemic associations like vaginal delivery, NICU care, oxygen therapy, intravenous drug use in NICU, and broad spectrum antibiotic use before developing endogenous endophthalmitis. Typical presentation was conjunctival congestion, cloudy cornea, anterior chamber exudates with no fundus view, but we also saw couple of cases with white eyes, no conjunctival congestion. 40 eyes had clear cornea, 19 clear lenses, 12 presented with lens abscess, and 7 presented with retinal detachment, and 4 with choroidal thickening. The commonest organism was Pseudomonas aeruginosa. We also found fungi as well as gram-positive cocci in the culture, and the culture yield is very less. It was 40%. The prognosis was poor, with 50% of eyes going to thysis bulbi and the rest with macular scar sequelae. So it's very important to advise amblyopia therapy in these cases. If the baby presents, one eye is affected and you are doing a vitrectomy, there is high chance of eyeball elongation if you remove vitreous from a neonate. So these patients, those babies to be followed regularly, and myopia is a rule if you have done a vitrectomy. A minimal vitrectomy, that's what we have started doing in these babies. Thank you.
Thank you, Dr. Samira.
Okay, yeah. No, carry on. My only query was that was the vitrectomy really required? You see, one-day-old child, and you see that fungal granuloma. We could have tried this fungicidal drugs. Ultimately, amphotericin B is the drug which ultimately cured, and baby was quite lucky that he responded.
Yeah.
Not all fungi respond so well. You see, despite amphotericin, despite all these azole drugs, I could have tried,
I have, yes, that's a very good question. We actually look at our series of neonatal endogenous endophthalmitis. We realized those babies who received only systemic antibiotics or antifungal agents, or they received only vitreous biopsy, not vitrectomy, then they did very poorly. And 80% of them went to phthisis, or almost nil with nil visual prognosis. So we have actually switched to protocol-based treatment for these babies, and we are doing a good vitrectomy. We are trying to remove the exudate, whatever possible, and with intraocular antibiotics or antifungals. So that's why we kept on injecting, as well as we did a good vitrectomy in both eyes.
That's perfectly okay. Post-op management was fantastic. You kept on injecting. I think that is what saved, ultimately eradicated the fungus from the eye. But a lot of these patients of fungal are recalcitrant despite
yes, true.
Also, was it necessary to do the invasive procedures in both eyes? Since you were already going in with vitrectomy, what was the need for biopsy in the other eye?
Yeah, that's a very good question. This baby was already diagnosed with fungal urosepsis as well as bacterial septicemia in the blood. They have, there are culture positive blood culture was yielding some bacteria, and the urine culture was yielding fungus. So we wanted to, we didn't think that both the eyes are having similar organism. So that's why I did both eyes biopsy.
See, the thing is, it's a one day old baby.
It's
And-
it's 1 month old baby.
One month old baby, okay. The lesion is classic of fungal endophthalmitis. The focus is very small, okay. And the yield of the organism can be best from the left eye, not from the right eye, because the lesions are very, very tiny in right eye. Left eye, it is a definitive, a small lesion popping into the vitreous. I would have done a single port aspiration biopsy of that lesion.
In left eye.
In left eye.
In left eye.
Yes. And then
Nothing there.
reconfirm. Though clinically I am sure that 80% this is fungal. The very first slide we said it is fungal endophthalmitis, which would have saved the complications of vitrectomy in a neonate. If it is not neonate, you have done in an adult, the questions will not arise so many.
Samira, the other thing is,
Yes, the point well
one
taken.
second, thinking of two things in two eyes. You see, even if you have to take biopsy, one eye is good enough, na? Why are you thinking that this organism will be different and this will be different in endogenous?
Yes, point well taken, but it's very difficult to have a geo clearance again. So that's why I.
In any case, we can keep
So
arguing.
at that point, I thought that would be the
agree
best.
with you. That is the point. Okay. Thank
Anybody,
you very
anybody,
much,
anybody
Samira.
from the audience
No,
would
no,
have
no.
done
Let us not
differently.
make it more controversial. We will move with Dr. Srinivas Jose.
No, it's a learning exercise
Yeah,
for
ठीक है,
everybody. It's
okay,
a learning
okay.
exercise.
Throw
Because
the-
time is only one talk is left.
Yeah. Okay.
She's a brave.
Heroic, yeah.
But excellently, ultimately, you see, whatever God does is good. Both eyes are doing well, so we are happy.
Thank you.
With the outcome, we are very happy.
And it's very important to not only to get a positive result in microbiology, it's important to to remove the exudate,
The only
because
difference- the only
fungal
difference
sometimes
we-
increases with time. Even if you inject, sometimes the exudate increases. So that's why I wanted to take out the entire exudate from the right eye as well, so that it will not spread much. So that was also one thought behind this.
Yes, Srinivas, are you ready?
Thank you, Dr.
30 seconds.
Samira. Thanks.
But the reason we asked Samira was just to excite some discussion, because I may not have done biopsy in both the eyes. I would have done biopsy in one eye. And other thing is, I do not believe in this concept of minimal vitrectomy. Once inside, do a total vitrectomy.
मुश्किल है. Especially when there's so much localizing lesion.
Do a complete vitrectomy in a newborn, because we do ROP surgeries and we have seen, and there is elongation of the eye,
Eyebrow.
and it causes myopia, minus 20, minus 15, or sometimes minus 30. So a minimal vitrectomy we prefer if the infection is localized. If it is a diffuse one, definitely a good
Yeah.
vitrectomy. If it is a localized one, we try to focus that area. Thank you.
Yes, Srinivas. Srinivas is a brilliant, surgeon, vitreous surgeon from Karnataka, and I am very fond of his surgeries, and he shows wonderful videos and has won Resbakla Award not once, not twice, not thrice. So many times? 6 times, I think. 7 times. So therefore, you should watch his surgeries with a lot of awe. Yes, Srinivas.
Thank you, sir. Thank you very much for that kind introduction. Thank AIOS for this wonderful opportunity. So here I'll be quickly speaking, upon the sutureless SFIOLs. How do we go about it? So now let me quickly go into a few of the videos. So this is how, if you have a decentered IOL with the CTR, so you can just remove the CTR, and then since it was a 3-piece lens, you can just fix the same lens. So I'll be showing different techniques of how we can fix the same lens. So here I just try to dial it. I made a flap, made a Hoffman pocket, and then hold it at the edge or the tip of that haptic so that it doesn't bend, and then make a small tunnel using a 26 gauge or 27 gauge needles, and then just try to pass it through the Charot's tunnel. So this is a pretty simple technique, not much of disturbance, and this whole thing was just over within 30 minutes. So this is another case where it was aphakia, and you can see the superior part of the area there was a bleb. So here what I am doing is a modified Sergio Canabrava technique using a 6-O-Prolene. So I have already threaded that 6-O-Prolene into that 30 gauge needle. It's a 30 gauge thin bore needle. It's not a regular needle. A regular 30 gauge needle, this Prolene doesn't go inside. So I'm now bringing it out through the tunnel, and then similarly on the other side, you just pass that 6-O-Prolene and then bring it out. So once we bring out this 6-O-Prolene, just pass it through the eyelet of the SFIOL, as you're seeing here, and then slowly flange it. So once we flange it, make sure you pull it and check it. Otherwise, sometimes if it's too small a bulb, after putting into the vitreous cavity, it might give away. So after flanging on both the sides, just introduce it, stretch it on both the ends, cut it, and then flange it. So this is also a very interesting and very simple technique of how we can handle these kind of aphakics. Now this is another interesting case where we call it as a dangling SFIOL. You can see one haptic of the SFIOL is dangling. Now instead of removing the whole SFIOL and putting it back, what we can do is we can repair the same dangling haptic can be bought. So now with the railroading technique, I'm just trying to pass that. This is a 9-O-Prolene. Now catch the end of that 9-O-Prolene, and bimanually you can just thread it inside in the vitreous cavity and bring it out, make another entry, and then use that ILM forceps and just bring out the one which you have already threaded into the eyelet, and then just tie it under the flap. So now you can see this is stable on both the sides, and we did not have to explant this IOL. Now this is another case of again the subluxated SFIOL, where this is another case where we saw it dangling. Now these are the cases which are coming up, which were earlier operated 15 years back for the sutureless for the sutured SFIOL. Here the one which I showed before was using a 9-O-Prolene, but here we are using a 6-O-Prolene. So again, as you can see here, make a small entry into the AC, then pass that 6-O-Prolene through the 2 mm long needle track made. You can see here I am just passing it through the needle track made, or you can thread it before passing it into the pars plana route, either of the one, whichever best suits you. Here what I am doing is trying to thread it into the lumen of the 26 gauge and externalize it. And once we externalize it, now take this other end, just flange it first because it should not slip down. Then now use this another end. Now once we put it into the vitreous cavity, make sure that when we are dialing into the vitreous cavity, it should be upside down, not downside up. Now you can see here, hold the eyelet carefully and then just thread it inside in the vitreous cavity and then bring it out. So once this end is bought out, now you can just flange it and make sure that the bulb is sufficient inside, sufficient on a bigger size, and then just pull that the other end, it gets fixed. So it's a nice centration what you can see here. Just cut this end using a heat cautery, Bovie heat cautery. You can just form a small bulb and make sure that the bulb is made in such a way that it's a rounded shape and it goes back into the track of the scleral track what we have made. Or in case if it is little larger, you can still tuck it under the conjunctiva, but I would suggest to make a flap in those cases. Now indented examination was done in this case, and so this is the post-op of that patient doing really well, post-op day 1. Now coming to the last one, this is the anaerobic SFIOL. In anaerobic SFIOL, again similar technique of this modified technique of Sergio Canabrava, it can be used. So here I am just bringing out both the ends, and this, the what modification is being done here, it's under the flap. So even if there is irregularity of the bulb, using the Bowie cautery, it will not matter much because it is covered under the flap. So this is the last video I just operated a few weeks back. This was again a subluxated IOL, 3-piece IOL. So instead of removing, what I thought was I'll just first complete the vitrectomy and use a 27 gauge entry here. Smaller the gauge entry is always better, lesser the chances of slippage. See here I have just marked it. Now you can see here I am using a 27 gauge trocar cannula, and I make a small Z entry there and then catch hold of that haptic, bring it, externalize it, and you can just flange it, or you can say this modified Yamane technique kind of thing. Because I didn't want it to explant this IOL because the IOL was very much of the correct biometric calculation. So it had just slipped away, there was no back support because of trauma. So again here you can see I am using a ILM forceps in a fashion where I entered using the ILM forceps in a Z-type fashion, catch hold of that tip of that IOL and externalize it. And once you externalize it, flange it properly and put it back into the track. So this was how it was shown after surgery. This is post-op day 1. You can see the scar because of the trauma he had, and the patient is really doing well. So thank you very much for the patient listening. Thank you.
A very nice effort in the first 2 cases actually. It is really tough in case of vitrectomized eyes doing all that maneuvers inside, because the eye will also be collapsing in these cases. It is not like anti-segment person doing a scleral SFIL where the vitreous is found, vitreous is there and it's very supportive to the globe. So in this it's very, very tough in vitrectomized eyes, and he has done very nicely. But my question is that you could have adapted the last technique in the first 2 cases as well.
No, that's what, sir. The
Yeah,
first
that's
one
what-
which I
yeah.
showed, the chariot stake tunnel which I did was a pretty old
I know.
thing.
Previous
So
cases.
yeah,
yes.
it was very old video.
Yes.
Even the video quality
But
also you can see.
Yeah. Only suggestion I have is you have not made a scleral flap in the last case.
Sir?
You have not made a scleral flap in the last case. Actually, we always should do, because I have seen patients coming with only for the symptomatic, the lot of pain because of this tip from the other surgeons, and I had to use a scleral flap to make them comfortable.
That
That is very
I
much
definitely
required in
agree with that
scleral
point,
SF.
sir.
Yes.
So here what I showed was
In
where it goes back into the track. See,
I
I
know
make
that.
a Z entry kind of thing,
Yes,
and
yes.
that bulb will be lying in the scleral track. But in case the bulb is very irregular, at the same point of time, you can
Erodes.
always make a flap also at that point of time.
It erodes and it will
Yeah,
come
correct.
transconjunctivally, and it will be
So-
very symptomatic for the patient. Anyhow, we are on time for this session, and we
Thank
are
you, sir.
closing
Thank
on
you very
time.
much.
Thank you all for your patient listening, and I thank all my co-chair and all the discussants. And thank you very much. Okay, we are closing this session on time.
Thank you.